All right, it's recording. And yesterday's up is put up. I'm just waiting for YouTube to approve it. Evidently, somebody reported my channel. So I don't know why they reported my channel. It's great. So yesterday's will be posted later today. So let's look at this anterior view here. So number one, she's smiling. No one ever smiles in the posture assessment. So we got some suspect things going on here. Right? No one wants their posture smiley accepted. So let's look starting from the top and moving down. Right? So let's look at our earlobes, or our tops of our ears. There's our tops of our ears. There's the bottoms of our ears. Are we pretty even? What do you think? Yeah, ears look pretty good, right? She's got a little bit of a crooked smile, but hey, we won't judge, right? Because this one's down low, this one's up high, but hey, we won't judge. Let's get a smaller line width. There we go. All right, so now let's come down here. We're looking through the neck. Do you see how her neck has a little bit of hypertonicity though? That would be just something I kind of document. It's not part of the posture assessment. Do you see how tight her neck is? What's that probably tell you about her? Is she relaxed for this picture? Yeah, right. She's not relaxed for this picture. Could be stressed, right? But I'm thinking probably she's like, I can't believe they're taking a picture of me in my posture, right? So then let's go down here. She's smiling too hard, exactly. She's like, get this over with. Let's go down here to our AC. That's way too thin. I wanted a thinner line, but that was a little too thin. That's like you can't even see it thin. All right, so now we'll go down here to our ACs. ACs look pretty even. What do you think? Maybe a little bit of drop off on the left, but not much. Not something that we're going to correct. And again, I'm guessing probably even looking at her biceps, you can see some tonicity in the bicep going up through the shoulder. I'm guessing she's probably actively correcting her posture. Yeah, it'll just a tiny bit lower, right? And so if that left is a tiny bit lower, we may try to correct it slightly. But how are we going to know if that left being lower is a problem? What would tell us that that left being lower is actually a problem for her? What do you think? Yeah, strength exercises would be a good idea. Good. Yeah, neck pain, any sort of a complication, right? She's like, you're like, oh yeah, your left shoulder is just a little bit lower than the right. And she's like, oh my God, yeah, I didn't think about it, but this whole left side has been sore for the past couple of days. That tells us that she's got some sort of a little bit of a pathology going on. And pathology doesn't mean disease. Pathology just means something's going on with her. And then we know it, right? If she's not presenting with any pathology, then this minor change, yeah, not a really big deal. The one thing I do notice about her is this here. When I color it in, I didn't know I get the color time. Right? Do you see the difference in the space between her arms? Yeah, right? Her trunk might be shifted. Yeah, that could be right. She might not have tightness, right? And that's the thing here is I'm looking at this going, okay, so could this spacing of the arm be what's leading to that right and left acromion difference, right? It looks like she's a little bit more relaxed on the left side. Left side just kind of there, where the right side, she's got that little bit of tone going down through these biceps. And she's definitely got some space difference there. Again, is it a problem? We don't know until we've taken a look at the patient and see if they have any pathology, right? Get rid of my color in here. So coming down, let's look at our headlights. So there's one headlight. There's another headlight. Headlights look pretty normal, right? They're pretty even. Again, she's got some of that instance of a little bit of trunk shift, but again, it's such a minor trunk shift. And when you look at the next person, you'll definitely see, right? You'll definitely see the trunk shift on the next person. So, okay, we're good there. I'd love to get on the greater trochs here, but you really can't. So there's about where her one greater troch is. The greater trochs are just a little bit off looking at it, right? Which is weird when I look at it. She's starting to posturally correct for her upper body because now one's higher than the other. Do you see a little bit? So if I highlight that a little bit more, now her hips are a little off in opposite of the shoulder. Do you see the difference? Right? So her right shoulder is a little bit lower, left's a little bit higher. And then when you get down to the hip, it's opposite. And what she's doing is just correct self-corrected posture, right? She's making sure her center of balance is even. Let's go down here to the knees. So we're going to look. That's not quite on. Let me get that other one there. Draw. Thank you. So there's her lateral epicondyles. They look pretty even. Moving down, calf tonicity looks normal. When I'm looking here slightly, do you see the difference in the feet here? One's a little more outturned. Can you see that? Which one is the more outturned foot? Yeah, the right is outward a little bit more, right? So we call that, what do you call that when that foot has the toes going outward? Not eversion. Eversion is when you kind of roll the foot. Okay. You could say the toes are abducted. That's a possibility. Usually what we're just going to say is it's really simple. We just say they have toe out. Right? So evidence of right foot toe out. Yeah, right? Duck feet or penguin feet if you're looking at mine. Because if you ever watched me walk, my feet kind of go like this. I mean, like majorly. When I stand up, my feet are just pointed absolutely out, right? And we'll talk about what causes that when we get into the femoral angle of the neck, right? Because the femoral angle affects the way your toes are pointed, that anteversion, retroversion type idea, which we'll talk about. So really looking overall, I mean, her malleoli are kind of right on that white line at the bottom. Overall, she has a pretty good anterior posture, right? I would not believe she has a pathology. She may, but here's the deal. Let's say she's coming in and she's complaining about low back pain. That's why we're assessing her posture. She's like, man, for the past 5 or 6 weeks, I've had this really bad low back pain. I can't get rid of it. And we assess her posture and her posture looks good. What's that probably lead us to believe? Is posture part of her low back problem? What do you think? Yeah, probably not. I'm thinking that just if she was coming in complaining of low back pain and her posture's good, we're like, posture's not it. So then we start looking at the other stuff like musculoskeletal nervous. Because we're like, okay, posture, pretty good. But maybe she has a muscle imbalance that's causing it, or maybe she's got a nerve pinch that's causing it. But overall, her posture's good, right? I can't believe she's maintaining her smile through this whole thing. She's been standing here for hours for us. I mean, she just sits there. Look how stone solid she is, just sitting there on our screen for us. Psychopath. All right, let's go with purple for the other side. So let's look at number 2 here. Yeah, you can. Yep, let's look at the center line. Good call. So looking down the center line, let's see how we do. Actually, let me get a straight line. Eraser. Because, all right, so let's start that center line right up here. Let's run it right down through. Let's make it straight. There we go. All right, so looking at center line. Maybe a little bit shifted to the left in the head, right? You see how the nose is a little off? But that also could come down from the shoulders. So we're going to look at that when we correct the shoulder slightly to see if it fixes that nose. One of the things, and this will come into play, you know, when you're looking at the other thing, especially when you're looking at a female, and this is not offensive or anything like that, but let's look across here. When I make that cross there, could you see what might throw off her shoulder? And I'm guessing here there's two things that could cause this. Do you see what does anyone see anything when I make that cross that looks off? Looking at the chest cavity. So what I'm looking at is whether, yes, thank you, Anthony. Great, good job. Definite one breast is lower than the other. Now, that can be caused, that's exactly where I'm going with it. That's exactly what I was thinking here, Tyler, is more than likely there's a volumetric difference, right? Guys, here's the thing that you may not realize. Breasts aren't even. Right, exactly, Kelly. Breasts aren't even. They don't naturally come to the same size, right? I know that we don't have, unless you got moobs like me, you don't really have that problem. But breasts aren't even. Our sister's not twins. I like that comment. So when I'm looking at her from this kind of that cross aspect, could that be what's throwing off her shoulder posture? Even a little bit of volumetric, right? Even a little bit of volumetric difference in the breast can throw off posture, because you've got to realize when the breasts are uneven, that's fluid and adipose, right? So that's a little bit of weight. So if you've got, even 2 or 3 pounds more weight over here, that's another reason doing sports bras. You're exactly correct, because that would give us a better option here, a better view, right? We could see a little bit better. The other thing we could do, and this is possible too as well, maybe her right bra strap she doesn't have as tight. That's a possibility. Or maybe the right side of her bra is worn out and we just don't know it. This is one of the reasons why we would probably do it in sports bra. But I'm just looking at that, and that's one of the things that's kind of cluing me into, that there's something off here. Now, am I going to walk up and measure those to see if they're volumetrically different? No. We're not going to do that. That is not happening. That is a great way to get a lawsuit. But we're looking at it going, hey, there's something there. No palpating. No. Unless you want to get palpitated. Going down, when we looked at midline, when we get down to the PSI, or not PSIS, but down to the pubis symphysis, we're a little off down there again. Right? She's a little off center. And that kind of goes with the face. So two things could be here. Either A, she's actually off center, like physically, we just didn't line her up perfect, right? Or she's leaning. Exactly. So we're looking at that. All this is going to go into our assessment. And we're just, our objective, we're just going to put everything we down here. So what would we type? So let's look at this. So we're going to type that one acromion is lower than the other. Which one is lower than the other? Okay, favor and right side could be definitely. So if we're going to document our acromions, which acromion is higher? Okay, right side is higher. Good. Going down through, we're going to indicate that she's slightly off midline. Pelvis is slightly off kilter again. Greater trochs, slightly off kilter. We're going to indicate, and we're not going to say by 1 inch, by 2 inch. We're just going to indicate one is higher than the other. That's it. You don't have to be specific, with inches or anything like that. We're just going to indicate. And she definitely has some of that right toe out going on the right foot. Great. So we've got kind of our anterior assessment. Does that make sense for the anterior side of it? All right, let's look at lateral. So I'm going to draw that vertical line first of all, because that was really easy to do. So let's start up here. Let's make it straight. All right. So let's look anterior, posterior first here, and then we'll start looking at the landmarks. What are you seeing right off the bat? I'm seeing text posture right off the bat. Yep. Okay, we got some leaning forward. What about the head? Yeah, that's why I said we've got some text posture going on here, right? You can definitely see a little bit of forward head there. You can see the angle back here at the neck. Around the shoulders a bit, good. Right, it's not through the center of the ear. It's not through that external auditory meatus, as we like to call it. And again, she's smiling. It's very creepy. I'm getting a little concerned. She's starting to be a sociopath. She's plotting her deaths, exactly. Going down through, when we get down to the hips, it looks pretty good, doesn't it? What do you think? Once we get past the shoulders, we're starting to straighten out. Yeah, she's getting pretty solid going down through there. I'm guessing that's even going through the lumbar bodies at the right spot, right? So once we get past that kind of rolled forward shoulders, her posture evens out. You know, the only thing I'm looking at is, again, when we get down here, she's got a little bit of hyperextension of the knees. So let me find her right about there is going to be the start of her. So if I draw that, she's got a little bit of hyperextension of the knees. And that's what's causing that lateral malleolus to be behind the center line. So she's got a little bit of backwards knee. Do you remember what that was called? Did Dr. Johnson talk to you guys about that last semester? When you have a backwards knee, when the knee locks out. So what is, do you guys remember, do you guys know the Greek term for knee? So the Greek term for knee is genu. Right? So this is again where we get into these weird Latin and Greek terms, right? So genu is for the knee. And we're going to talk about a bunch of different knee pathologies when we get to the knee. But genu means knee. And then genu recurvatum literally means backwards knee, recurved knee. So what she's got going on here is she's kind of got this going on, where that knee goes backwards. She's got a little bit of hyperextension going on. Again, how are we going to know if that's a problem for her? We're going to ask if she has problems, right? Does she have knee pain? And I guarantee you, when you're working with ladies, you're going to find out most ladies have some knee pain. I mean, if I just kind of ask about the class, how many of you ladies actually have some knee pain on a regular basis? Right. So why is it you have knee pain? What do you think? These two for PT. What do you think causes you to have knee pain versus guys? Yeah, Tele-Alta is one of them, right? Weight can be a problem. The hips. The hips don't lie, right? The hips cause a problem because they're slightly different than men because, well, you have to deliver a watermelon, right, at times. But when if you have a little bit of extra weight, plus you've got that odd knee angle at the hip angle with the femur, that leads to knee pain, leads to PFPS, patellofemoral pain syndrome, right? So she probably will tell us she has pain. And by looking at this backwards knee, I'm going, yeah, you probably do have a little bit of pain, right? I mean, look at this, her lateral malleolus is a good, what is that? At least an inch off where it should be. Now I've got a triangle. Illuminati confirmed. No? No one? Okay, fine. We get down to the feet again. Can we see the foot out to toe out again? Looking at that right foot? Yeah, that's definitely an issue we might want to address. Like, okay, that's definitely one of the things. She may have a little bit of sway back here. I can't tell. A lot of times when I'm wondering if they've got sway back, I'll have them lift their arms up for me and hold them so I can take a view of what they look like with their arms up. And again, sway back is where you have that really hyperlordotic curve. But from this patient's standpoint, overall, you know, she actually doesn't have too bad a posture. And I'm guessing this patient really doesn't have much pathology. So then once we've kind of assessed her, we don't have a posterior view of this patient, unfortunately, only the anterior and lateral view. Once we've kind of assessed her, the next thing we're going to do is we wrote down all our notes. Now we're going to come back and correct her. So I usually leave her in whatever posture was the last one we left in. So right now she's in that lateral posture. I'm going to leave her there, and I'm going to come start correcting her. So now before I put my hands anywhere on her, what am I going to do? Yeah, consent. Is it okay if I correct your posture a little bit? I'm going to put my hands on your shoulders and your hips a little bit just to correct some of your posture, right? With her, one of the first things I'm definitely correcting is that head and shoulders, right? So I'm going to try to bring her chest back, and it'll probably fix the head as soon as we fix those rolled shoulders, right? So if she's like this, I roll her shoulders back, it naturally, so roll your shoulders forward, and look what happens to your head. It automatically comes forward, right? Turn here. So here I am. I roll my shoulders forward, my head goes forward. I straighten my shoulders back up, and my head automatically comes back, right? Because of the tightness of the neck muscles. So just by correcting, going, okay, so we're going to push these shoulders a little bit backwards. Once we push the shoulders back, then we have to go back down and reassess everything. There's a slight anterior tilt. Yep, definitely. Not as present in the anterior view as in the lateral view. That's why I said I think that would be one of those reasons why I'd have her lift her arms up, because I'm curious if she's got sway back. And again, we naturally are supposed to have a little bit of lordotic curve. And you guys just went through lifting, right? And when you're lifting, what are you supposed to do to that lordotic curve before you lift? Or what should you do? So if you're lifting, you should actually increase that, right? Well, depends upon what emphasize it, right? You're going to emphasize is the good term, right? Stick the booty out. That's perfect. That is exactly actually what I usually say when I'm teaching that, right? Because you want that back to be as insufficient as possible, right? We kind of want it shortened so that we don't use it and we're using something else. Because when we have it all tight and we start using it, we have that great range of motion. So we want to make sure that we make it a little bit insufficient so that we don't use our back when we're lifting. And that may be something we do with her. We may have her lift something and see what happens. So she says, oh yeah, every time I lift, I get a little back pain. Well, then I'm going to also assess her lifting technique, right? I'm guessing we correct those shoulders, most of those lateral problems go away. Now the toe out, we can fix separately, right? That's not really a true lateral problem, but looking at it, something we may want to kind of keep an eye on. And we'll talk about when we get to the hips, what could cause that toe out. A lot of times we're uneven in our angles of the necks of our femur, and that may cause one foot to go out more than the other, right? So that's something we'll pay attention to at her as well. Anterior view, we got to tip it a little bit, right? Come in and tilt her a little bit. And then once we correct, again, I usually start up at the shoulders. Once I correct the shoulders, I'm going to go down to the hip, correct the hips. Once I correct the hips, I'm going to go down and correct the knees. And then I'm going to go down and correct the feet. Looking at this, if you had to think, what side do you think is her dominant side? Just looking at her. Okay, good. Yeah, right? Correct is right. I'm looking, that's probably where all these problems come from, is she's right-hand dominant. And it's really unique in the clinic when you first get a left-hander, because you're so used to seeing right-hand dominant people that you get a left-hander and like, oh my God, everything's different, it's backwards, right? Because left-handers are kind of the oddballs. And hey, right there, exactly. Right, we are the oddballs out. You know, it's funny is when you typically are looking at somebody that's typically left-handed, they're more of an artistic person, and obviously I fail at that. I'm just saying, I am not the artistic person at all. All right, so does that make sense though? Are there any questions on looking at her? Because the next one's got a few more postural problems. Does this patient look pretty good? Okay, good. Let's clear these drawings. We'll stop share here and we'll go to the second picture. And my second picture, which one is that? That's her. That's my psychopath. Here's my second one. All right. Here we go. Oof. Right? We got some issues here. Let's get my annotation up here. So, why is my screen sharing pause? There we go. So we'll do this one second. We'll do this one first. Left, right. All right. She's ready for a fight. Yeah, the other one was very, very pleasant. She looks like she's ready to kill us. Let's draw our vertical line in here. All right, so I'm gonna do the same kind of horizontal line here as well for her. All right. She definitely has got some murder in her eyes. She's a stretch. All right. And again, you know, looking at this, we've definitely got some issues here. If you don't think there's issues, you've got issues. And Justin, if you need to go, you're free to go as well. You at least made it through one of them. On this patient or the last patient? Yeah, this one we're looking at. So this one I'm looking at, it looks like, which leg do you think is more tense on this patient? What does everyone think? Okay, so I've got a right, I've got a left. Left is dummy shorter. I like that one. I'm looking, and it looks like, I would agree, I'm thinking that she might actually have some short leg or a decreased leg length on that left side. I'm not sure yet. Definitely what I'm looking at when I look at this is this knee is almost in full extension. This knee is a little bit flexed. Can you see that? Does everyone see what I mean when I'm looking at one's an extension, one's a little bit flexed? So this one may be the tighter leg, and we don't know yet. We'll work on that. But definitely he's got something going on at those knees. She definitely has got something going on all in general, but she definitely got something going on at those knees. Does that make sense for your question? Yeah, that's okay. We'll have the recording for you. Don't worry. Thank you I think it was Dylan that suggested a recording. I don't remember who, but all right, let's start tearing apart this woman because she's definitely got some issues here. And for some reason, something is really off with that alinabod to me. Either that or they took that second picture at an angle. It just looks weird to me. All right. So looking at her, let's start up here let's just do the vertical line to start with. Let's do it a little differently here. So let's look at the vertical line. What are we seeing vertically? What do you guys see vertically with that that line bisecting her in half? Face looks good. Okay, good. Maybe a little bit leaning left. Yep, we're going to get there, right? Yeah, lower extremity, we got less gap on one side than the other, definitely. Especially when we get down to the foot, do you see how the line doesn't fall directly between the feet? So we might have some agony of defeat here. Come on, that was good. Get it? Agony of defeat. Runners suffer that quite a bit, the agony of defeat. Right shoulders higher, good, right? So looking at this, I'm already noticing we've got something going on with that left side of the body. Something's off. Not sure what yet. And again, this would have probably been a patient that would have been better off in a sports bra so we could look at it. I'm not sure that I'd ask her to put a sports bra on because I'm pretty sure she might steal my soul. Just looking at this picture, I think she's going to steal my soul. Let me zoom in a little bit here. See if it messes up my lines or not. Yeah, it messes up my lines. Never mind. All right. So vertically, we've definitely got something on that left side. We know that just from that vertical line. What about at the chest level? And that horizontal line, do we have something going on there? It looks pretty even, honestly, overall. Right? But again, we've got a postural thing going on, definitely. I don't think we have volumetric issues here. I think we definitely got postural issues. Let's go up here to her ears. So she's got her ears are a little off, right? Definitely. Yeah, we got some things going on in those ears. Something's going on, right? Mickey is not happy. There's two smiley faces coming out of her ears. She's definitely got some space, some difference there. But again, her head overall is pretty even. So here's the thing with this ear one. I'm thinking, looking at this, it's not necessarily that there's a postural issue with the ear. She may just have one ear that's smaller than the other. So we want to check that. Maybe one is. And if that's the case, move on, because her head is pretty good. It's not, her head's functional. So once we get past the head, we got problems. All right, so let's look. Let's find ACs. So right about there is one AC. Tiny ear syndrome, right? TES. All right, we got some issues with the ACs. What do you think? Yeah, that right side's higher. So we're already starting to see, oh God, there's where it's starting to come, right? We got that left kind of drop down. Now, I'm looking at this patient going, I wonder if she's left-handed. I don't know, because I don't know who she is, right? But I'm wondering if she's left-handed and has a tendency to lean towards that left side. It's possible. That may be one of the problems here. Or she has other pathologies as we go along. Even when I get down here, let's look at even the elbow folds, right? So here is the top of her elbow fold, right? There's top of her elbow fold on that side. So even that's a little off. Yeah, definitely, right? Shirt even looks off, definitely. Yeah, so there are some keys even in clothing that we can see that are different. So I'm going to go down. Let's look at our hands now. Actually, let's go down, let's find our headlights. So here's one of our headlights. I'm guessing, again, I'm not palpating, so now we got a reverse shift, don't we? Right? Why is that reversed now? What's she trying to do? Yeah, right? So she's probably got, she might have kind of something going on like this. And she's trying to correct for it. So that might be something we're going to watch for. So we got something going on here. That just gave her an even creepier smile, because now she's got two eyes down here. Greater trochs, there's styloid. There's styloid. Greater trochs aren't too bad, are they? Looking at the overall greater trochs, maybe a little difference, but not too much. Let's find our, there's the top of that knee. Knees are a little bit off. Right, if I draw a straight line through there, let me just do a straight line. So let's go right through mid patella. Definitely got something going on in the knees. And again, what could be happening here is A, she could have a short leg, or B, that leg could be short because of everything else is kind of off, right? So we're going to measure leg length to determine that eventually. Let's do another one down here at the ankles. Even down at the ankles, it kind of looks off. Definitely have more meat showing on that one foot versus the other. What about position of the feet? How do the position of the feet look? Like actually forward and out to the sides. Toes look pretty good. What do you think? So we can always say to her that her feet at least look great. They're a little off, but her feet look great. We want to give her some compliments because I think if not, she will steal our soul. I'm even looking here at the eyes. I hate to say it, but her eyes have a slight angle to them. Not much, but there's a little slight angle to them. What else? Is there anything else you guys see? What about the internal rotation of the shoulders? Anything about the internal rotation of the shoulders you see? Is one more internally rotated than the other? Yeah, right. Right looks a little bit more internally rotated, whereas the left looks more at rest. Right? The left looks very much at rest. The right's kind of turned in just by looking at with the position of the thumb. But then again, is that actually internally rotated, or is the problem that this shoulder is lower and so it's just hanging that way? Right? So we've got to determine that, and we'll determine that when we start correcting posture. So where would you start correcting her at? What do you think? If you had to correct this anterior posture, where would you start correcting her at? Would you start at the shoulders or would you start at the hips with her? Okay, so I've got a shoulders. Do I have anyone that would start at the hips? Okay, so we got a split thing here. Here's the good news. Neither of you are wrong. The last patient I would have probably started more at the shoulders just because her problem was more of like that text posture. This patient I may start at the hips because of that leg oddity. Just because I want to see if I correct the hips, if the legs straighten out. If they get to, my bad, Dylan? Dylan it? I may start at the hips with her just to see if when I do that, if the tension in both the knees corrects. Oh, okay. The good news is she's got Under Armour shorts on, so she's protected. We're safe. That'll keep us safe. Here's the deal. Is once we correct either the shoulders or the hips, whichever we correct, we're going to start causing problems elsewhere. So we got to keep, I love it, accident. Dylan, I sent you a message on accident. So looking at these, once we correct one of these, we're going to have to get on and multiple correct everything. So documenting this, we're definitely going to document that the one acromion is higher than the other. The one ASIS is higher than the other. Greater trochs look pretty even. And that's what we're going to do is we're just going to go down the list of those landmarks and talk about what we see. All right. Overall, though, I'm guessing probably she has some back pain. But I'm guessing that's probably what's causing this face. She got some back pain going on. We're going to make her better. Okay, are we okay on the anterior view? Anterior view okay? All right. I just want to erase this stuff because I want to make the lateral view a little bit bigger here real quick. Nope, that was a little too big, huh? There we go. All right, let's get our straight line going here. So we'll start up here, straight line. We got some issues, don't we? Yeah, right? Even if we assume she's not perfectly lined up with the alinabod, and let's say we're saying, okay, you know what? Maybe she's not perfectly aligned up, so let's align it up with the ear hole. And in reality, we're going to go here and say that's her center line. Even that's off, right? So I'm not going to do that because I want to stick with, I think they lined her up properly. I think it's just her posture that's the problem. So there's the mid of the alinabod. We're going to come all the way down. So there we are. We got our line. So we got some head forward. Definitely, right? What about shoulders? She doesn't have forward rolled shoulders. What does she have? Yeah, kind of back rolled, right? This is an oddity, right? That's why I love this picture, because this is something we rarely see. And the nice part is once we correct the head, that's already where we want it kind of. We just got to correct the head and then everything will kind of fall into place, right? So just thinking about this, if she has that forward head posture, what do you think muscular wise is causing that forward head posture? What muscles are probably tight? Good neck, good. But what muscles? What muscles would cause a forward head? Levator could. Okay. Yep. Depending upon how the tilt was. So when I come way forward here, right, a lot of these muscles in the back of my head or neck are the main muscles. Traps are actually going to be a little stretched out. But what about up here? What muscles might be? Platysma, might sternocleidomastoid, right? And what's the other one up? What's the triangle ones on the neck? The ones that I like to call are the deltoid of the neck. The scalenes. Yeah, so we're going to be looking at all of those. Just looking at her platysma is a little tight. She doesn't shave. I think we're okay. Right? I think we're okay. Well, she may shave, but we're not going to ask her that because that would get us punched. Ironically enough, even though she's got a forward head, her ears are way back. I think that's just we're going to call her Susie, and we're going to say that's just a Susie problem. I don't think that's actually a problem. I think once we correct that chin out, we're going to fix that. Susie scalene, exactly. So now taking a step further, again, we're taking a little bit further with this patient than we did with the last one. What kind of exercise are we going to have her do to kind of correct that forward head posture? Does anyone know? Chin tucks. Yep. Right? Some of you right now, if you put your finger right in that spot between the cleft of your chin and pull your head back, as soon as you pull that head back and do that chin tuck, a lot of you are going to get tightness and soreness right in the back of your neck. And if you get that, then you know that you've got a little bit of forward head. You probably should be doing more of these, creating that triple chin down here. Someday I'll get rid of that. Ooh, that hurts, right? Some of us have a double chin. Some of us get a triple chin. So we're going to maybe do that with some exercises with her, right? Shoulders are way back here. But again, once we correct this head, that may fix it. Once we come in and go, okay, that way, this may resolve itself. We definitely got some of this going on, don't we? Oop, that was a bad drawing. What do you think? Do you think we've got some curve going on in the spine? You know how I can tell we've got some curve going on in the spine? We got what I call little kid syndrome going on. Her butt's out. She might get offended if I drew that way, huh? It's not that big. She's definitely got some booty poking out the back. So that's what we're going to look at, what's causing this, right? And I'm looking here, look at these abs. Not saying that she's got rock abs. Well, that could be, right? She could have a badonkadonk, right? And that may be causing it. That's why a lot of times what I'm going to have her do is, again, bring her arms up. Let's take a look at that back and see if it's way out or if she's just got a little bit of junk in the trunk, and that's what we're working with. We got that, that's what we work with. But a lot of times people that have a little bit bigger of a booty are going to correct it with a greater lordotic curve because it's a lot of work to keep that kind of in line, right? And we're not even getting into body shaming here. We're just saying it's you know, when you're overweight, and I'm speaking from experience, when you're overweight, it's a lot of work. Well, no, the working out further butt can be good for the back as long as you've got a fairly, trying to come up with a good, politically, I can't get it politically correct. As long as you're not out of sync weight-wise, if that makes sense. As long as you don't have one side of your body anterior posteriorly larger than the other. If you do, you may have to work a little bit of that to get one of those sides down. And again, that's why, you know, a healthy diet, a little bit of weight loss is good for pretty much all of us. None of us, I mean, I don't know, I didn't really weigh, except for maybe Emily. Emily might be the closest to like 1% body fat out of all of us. And so there's my role model, right? Now, and here's the deal is, and we talk about Kim Kardashian, then we end up with other problems because all that plastic surgery that they've had done, that's going to throw off posture. The body doesn't adapt well to that. It's real. I'm talking about the other plastic surgery. All right, we're going to move on with Susie Scalene here. Greater trochs, definitely back behind things, right? Knees. Remember, where's this line supposed to fall at the knee? Where's that midline supposed to fall at the knee? Yeah, she got that Greek backward knee. Good. Not as bad as the other girl, though, right? But she does have it, right? She got a little bit of genu recurvatum going on here. Got a little bit going on, right? And again, that may be caused by the upper body. So once we kind of correct her upper body, that may resolve itself. We don't know. Because she may be like, ow, now my knees hurt. Well, that's because you've been standing with your knees going backwards all your life. Let's fix it. Line's supposed to fall posterior to the patella, right? It's kind of falling right through the patella. And we get down here, man, we got some space here between those lateral mal and that line. We got some issues going on. So with her, I think she's got a little bit of hyperlordosis. Definitely the belly, she's got a very flat belly. I'm not shaming her for her flat belly, but what I'm saying is her belly's very flat, which means she's probably really elongated in the belly. Right? When we get down, we got that genu recurvatum going on, and that's probably causing her a little bit of knee pain. Overall, looking at this, she probably has some hip pain too, just by her overall posture. I'm just assuming, I don't know for a fact until I start talking to her, right? But man, looking at this, there are some definite things we can work on with this patient, right? To help her get into better posture. I'd be curious with this patient here, I'd like to see her seated posture. Just because of how out of whack all this is, I'd really like to see what she looks like when she sits down. So I'm curious if when she sits down, yeah, if she's got that kind of, she starts rolling forward. If this is just kind of that military ingrained mindset, when she stands up, pulls her shoulder back, and kind of chickens her head out, right? And that's pretty common. And that's pretty common military, honestly. You'll see it a lot in ex-military or even just people that are in the military is when they stand, because we're told to stand at attention, we pull our shoulders way back, then we overall forget about our neck. And our neck's out here. We're walking around like Uncle Fester. The one thing I'm looking at, does she have some pelvic tilt going on? What do you think? A little bit, right? So let's see if we can, let's get rid of all these drawings real quick. So we can draw a pelvis here. Do I have a, oh, look, I got a diamond. So let's see. Mid-body. Oh, look, I didn't know we had a diamond. This is actually really cool. Can I move that around? No, I can't move it around. Darn it. Great, the diamond's stupid. There. Got a little pelvic tilt going on. And that's probably caused because her butt's sticking out. Exactly, right? She got a little bit of anterior pelvic tilt going on. I'd be curious if we level her out, and it's probably less than this. That's a little over exaggerated. But I'd be curious if we level it out, what happens to her posture. I'm guessing the back probably improves this, and I'm betting these knees will move forward. Right? I'm betting we give her a little bit of pelvic tilt correction. Those knees come right forward. She's even, we talked about this from the anterior view, she's even got some lateral pelvic tilt going on. Whoops, that wasn't a very good drawing there. Erase that one. right? When you draw the lines, let's try this again. There. So you've got some lateral pelvic tilt going on. And again, that's probably due to dominance, right? Dominance of one side over the other. We tend to kind of lean towards our dominant side. Why do we think we tend to lean towards our dominant side? What do you think? What causes us? Comfort, right? Plus, when we're writing, this is the way we write. Do you remember when we write? That's when we pick up a pen and we actually have paper and we write. I know, it's been so long. Back when you were in Dr. Ovreston's class, remember when you write? All right. So how does everyone feel about posture overall? And again, we're going to review and do a rehash of this when we go back to campus. I know I've got really bad posture. So what we're going to do when we get back to campus, one of the first days we come back with me, with Kines, I'm going to go stand against the wall, and I'm going to have you guys assess my posture as a whole class. I'm going to let you body shame me a little bit and figure out what you guys think. And then what we'll do is you guys work together and kind of even me out and get myself back to normal posture, just so that you can see it. But that's going to be part of when we come back to regular class, which I'm hoping with the meeting we're going to have today that it might be actually sooner than later. Yes. So, okay, what happens with people with flat feet? Because I don't have flat feet. I have duck pads for feet. So what's going to happen with people with flat feet and posture? What do you think is going to happen? So what's the point of the arch of the foot? We haven't gotten to the foot yet, but what's that point of that arch of the foot? Knees may cave in, right? But what's the point? So what's the point of having that arch? Does anyone know? Support partially, good. The main thing is shock absorption. So think about it. We've got this arch here, right? I'm trying to get my hand where you can see it. It's right. So we got that arch. Every time we plant down, the foot kind of goes like that, right? That absorbs and gives you the bounce in your step. You're exactly right. It gives you that shock absorption. If you've got perfectly flat feet, every time you come down, there's nothing there to absorb that shock. That means that shock is going to be transmitted up to the ankle next, and the ankle is going to absorb some of it. Then it's going to go up to the knee. The knee is going to absorb some of it. Then it's going to go up to the hip. The hip's going to absorb some of it. And eventually it's going to go to the low back. I'm using my arm as the example. But then it's eventually going to go to the low back, and the low back's going to absorb some of it. So what's going to happen is you're typically going to have a little bit of tilt towards that dominant side, right? Because again, we tend to go towards our dominant side. But a lot of times when you have that, your knees kind of cave in. And that's what we'll look at. They can also cave out depending upon your angle of your hips. We'll talk about, because there's two other genus. There's genu valga and genu varus, which we'll talk about, which are knock knee and then wide knees. You don't have to know those yet. When we get to the knee, we'll talk about each of those. But depending upon what your predilection is as far as up at the pelvis goes, will tell us where you fall. But definitely, if you have a purely flat foot, it is going to kind of wreck that's a straight line. Like for her, if she had a flat foot, it's going to wreck everything down in here, because she's going to be correcting for her flat feet. Bow-legged versus knock-kneed. Good. Right. Does that answer your question? Thank you. All right. Any other questions? Let me stop sharing here. I want to bring something else up. I'm going to stop the recording briefly.